Welcome everyone to another CyberSight live surgery. I definitely want to thank the CyberSight team for making this possible. I also want to welcome Dr. James Lehmann. For those who've watched CyberSight in the past, he's one of our top anterior segment surgeons. He's going to be doing two surgeries today. One is demonstrating cataract surgery in a truly dense nucleus, and that has been pre-treated with femtosecond laser. The second is a cornea procedure demonstrating DMEK. And certainly we've all seen in the last 10 to 20 years how the cornea revolution has occurred with lamellar keratoplasties. So joining us live from San Antonio, Texas is Dr. James Lehmann, who again will be demonstrating two procedures today. And certainly if you have questions, please look in the chat and I'll be putting content from CyberSight that will be relevant for this live session in the chat as well. Over to you, Dr. Lehmann.
Hi there. Thank you, Hunter, for that kind introduction. And thank you all participants for tuning in. It's around 11 in the morning here in San Antonio. And I'm going to start with a little presentation. So let me share my screen. The webinar today will consist of basically two surgeries, a cataract surgery and then a DMEK surgery. We'll start with the cataract surgery. And while my staff's getting the patient prepped and everything, I'll give you a little bit of an introduction. So a little bit about me. I'm in San Antonio, Texas in private practice, and I have volunteered with Orbis for the last 20 years, more or less. My financial disclosures are down there. And then the objectives of this webinar are going to be to review the steps involved in femtophaco. So this case I'll show you is a femtophaco case. And then I have done previous webinars where I went through the steps of phaco. So in this one, I'll show you some common intraoperative problems and how we can overcome them during surgery. And then we'll take a little break and I'll show you a DMEK surgery. But prior to that, I'll talk to you about choosing between DSEK and DMEK surgery. So kind of a little bit more intermediate level than just a basic introduction to cataract and DMEK. So the steps of femtophaco are like the steps of normal phaco. Basically, you got to do the laser, you prep the patient, incisions, hydrodissection, etc. I've covered these in previous webinars, so instead of going over them again, you can go to the cybersight.org website and search my name, and you can find previous webinars where I went over phaco basics. But the main thing is that each step in phaco builds on itself, and if you make an error early in the case, it has consequences throughout. So the benefits of femtophaco, probably about 60 to 70% of our patients choose femtophaco, and what it can do for you is it can make a constant nice 5mm rhexis, and it can make the divide and conquer part a little easier. It can do astigmatic keratotomies for low amounts of astigmatism. And if you're putting a toric lens in, it can sync with a Pinacam or with a topographer and put little marks on the capsule to help you position the toric correctly in the correct axis, instead of having to do the old-fashioned way with marks on the outside of the cornea. So it has some nice benefits, and it's evolved. Here's a video showing us what we do when we dock the laser. It's just a little suction ring, almost like a LASIK suction ring, and then fluid fills that capsule, and then the laser comes in, and you can see we dock it with the help of an assistant there, and then the laser goes through its steps. But that's docking the laser right there. So it's very comfortable for the patient. It's only about 15mm of mercury that they feel. It's not like LASIK where they feel 40 to 60 and the vision blacks out. That doesn't happen. And then in the first steps of femto, many times we'll use the femto just to make the rhexis and to break up the nucleus, and we'll still make our own para and main wound because you can make them a little more posterior. But there I'm injecting some lidocaine with epinephrine, and now we're filling the eye with viscoelastic. This is a dispersive viscoelastic. So this is what you'll see live here in a few minutes. You can see the fragment pattern there. Then this is a 2.6mm keratome. And then we use the Utrata forceps to peel off the free-floating capsulotomy. So that's the nice thing about femto. You want to make sure there are no tags and that nothing runs out. Then we're doing some hydrodissection. You have to do a lot less hydrodissection with femto, so that's nice. And then it's just divide and conquer. So we've talked about the steps. Now I'll talk to you about some pro tips and then some common scenarios that we want to overcome. So when you're doing cataract surgery, some things that I've learned over the years, over the last 15 years, are to nick the vessels when you're marking to mark your incisions. So when you're doing when I'm teaching patients teaching docs how to do cataract surgery, a lot of times they lose where their paracentesis is. There, I'm making it right there. So if you make it right at the limbus, you'll get a little bit of bleeding from the limbal vessels, and it'll mark the site for you. So you can always go back and find it, okay? The other thing is you always want to hold the cannula collar when you do OVD injection, because when you push the plunger, the tip of the cannula can go through the anterior chamber, which would be bad. So you never know how tight the tech has put it on there. So you always want to hold the collar of the cannula for any kind of injection. I do that for anything, for antibiotics, for BSS, or anything like that. When you're doing the main incision, you want to aim for a square shaped incision instead of a long rectangle. And then when you have a mature cataract, you want to make a very small rhexis to start and then kind of spiral it out. And then there's no need to dissect a mature, hydrodissect a mature cataract. That's another tip I've learned over the years. Lastly, I would say when you're doing cataract surgery and you're learning it, get the subincisional cortex first. That's the easiest during the irrigation and aspiration parts. So I'll show you that on this next case. All right, I'm going to go ahead and go on over to the surgery now, and we'll come back to the video or to the lecture. So I'm going to stop the share here.
You brought up a lot of great teaching points that I want to reinforce. I find a lot of people when they're beginning phaco minimize important steps. For example, the wound construction or the paracentesis. And a lot of people will struggle because their paracentesis is either hard to locate because they didn't nick the vessels as you described, or they go in at an odd angle and then they have trouble cannulating or going through. So certainly, as people are watching your surgery today, I want to call out specific attention to how you construct the wounds, not only so they are tight and not leaking, but also so that they're easy to identify and easy to enter. Certainly, we have a beautiful view here. The limbal vessels are in perfect focus. We can see the pre-treatment of the capsular rhexis, and you can see that there is a brunescent tinge to that red reflex. So we know that this is probably a denser nuclei. I know that you did the patient's right eye previously, and so this patient already knows what to expect. They're under a topical anesthetic. And maybe, James, or if you're ready, you can take over and tell us what you're seeing at the slit lamp.
Okay, guys. So thank you, Hunter, for that introduction. So now we're sitting here, and as Hunter said, this is a dense like 3+ cataract. You can see there's kind of a yellowish hue to it. And then these are some AKs that are already done here by the laser on her axis of astigmatism. And so we'll begin. So we're going to go in with the paracentesis here, and you'll see me enter to get about 1 millimeter width there. And so I nicked a little bit of a vessel there. You can see it kind of starting to turn red there, and that's going to help me to show where it is. People have different amounts of limbal vessels. And then now what we're going to do, this is just sugar cane, which is we call in America, which is lidocaine with unpreserved epinephrine. And then I'm going to inject that. You can see some bubbles kind of whirling around the AC. And then now this is a dispersive viscoelastic, and this is what I talked about where you hold the collar. This has a little plastic guard on it, but if it didn't, you would hold it right here so that it wouldn't eject out of that lure lock system. So that's just another pearl. So we're going to enter. I know where to enter because of my, see, there we go. See, it's got to mark the vessels. Huh? All right, there we go. And now we'll go across the chamber, inject the dispersive viscoelastic. You can see the bubbles kind of clear away. Nice deep chamber. And then now I have a pair of 0.12s, and then I have a 2.6 millimeter keratome. Now I'm going to fixate the globe by keeping the tips closed and entering my paracentesis. And then I'm going to enter right at the limbus, and I'm going to kind of come up, and I'm going to enter to that little mark right there. And then, so the extent, so I have about a 3 millimeter this way. So it's nice square incision. So I know that's going to seal nicely. Now, the capsulotomy has already been done by the femto, but we want to go in and make sure that it's free. So you can do that with the Utradas, or you can just lift it up with this hydrodissection cannula. You can see how it lifted up like that, and that tells me that it's free. So now I'm going to blot down and remove any gas that's there. See how little gas came right there from the laser? And now I'm going to go in and do the gentle hydrodissection. Especially on a dense cataract, you want to do hydrodissection pretty gently. You don't want a lot of viscoelastic coming out of the eye. You don't want to see the iris prolapsing. So you just go right under the anterior capsular edge there, and you can see some more bubbles come. And after you hydrodissect, you always want to push down again, release any fluid so that you don't get high pressure. You don't get the lens prolapsing forward. So a little more hydrodissection. All right, now you can even try to spin the capsule, spin the nucleus a little bit. it's starting to spin slightly, so we should be okay. But just to be safe, I'm gonna go back and do a little more. Okay, and then I blot down. So I think we're pretty good mobile nucleus now. So now I'm getting the phaco ready. I'll just move the camera so you can see the phaco tip. You want the phaco tip and the collar of the phaco tip to be, that's pretty good. You want about that much space there. I'm using what's called a 45-degree Kelman tip. This allows you to sculpt dense nuclei. And this is my second instrument. It's basically a horizontal chopper. It's not sharp at the bottom, but it has a little bit of an edge here. So I find these are the easiest second instruments. When you're learning phaco, kind of finding out what second instrument you like the best is part of the learning curve. So now I'm entering the eye, rotating my tip down, and then I'm going to go to the peristaltic quadrant mode here and just remove those bubbles that occurred right there. Okay, now I'm going back to the sculpt, which is high energy, low vacuum. And then I'm going to kind of try to find that suture line that was made by the laser. So I'm kind of cutting here. I'm using petals down about 50% there. You can see it's fairly dense cataract the way it moves, but I'm able to cut it. And I want to go in that same line that the femto already made. So I'm going to zoom in now, and we're going to try to assess the depth that we've done so far. So I can see here, look, I can put the phaco tip all the way there. You can see a little bit of a fracture line. This should be deep enough to be able to crack on a femto case. So I'm going to insert my second instrument, and I'll put them both in that groove, and you'll see me kind of gently spread them. And then I'm pretty easily able to crack that. That's about all the cracking that you need to do. You don't have to crack it all the way to the center. And now I'm going to rotate my tip 90 degrees that way to create room. And then I'm going to go out to the periphery of the nucleus, and I'm going to rotate the lens with my second instrument. I'm going to put this back down. I'm in sculpt still. And I'm going to continue and try to get about 80% depth. Now I'm going to put both instruments in the groove and open it. So now I have a free quadrant right there. And just to be kind of thorough, we're going to just do all 4 quadrants broken free before we remove them. You could remove that quadrant right now, but you risk kind of, it's a thick, firm nucleus. You could tear the capsulotomy. So you kind of want to have a little few more mobile pieces so things can move a little easier out of the capsule. So we're about 80% thickness there. Crack that. It's kind of attached in the middle still, like a leathery back plate. There we go. Now it's free. Now we rotate another 90 degrees. So this is the last heminucleus of the cataract that's intact there. I'm gonna go right to the middle of it. You can see it's fairly dense. Okay, those pieces want to come up, so I'm going to switch to quadrant mode. And then I'm going to eat those little pieces that are kind of wanting to come up. Now back to sculpt. Now I have a really good view of how far down I need to go. Okay, so that's really good. I'm all the way to the bottom almost. Now I crack with ease. And now they're free. I saw the red reflex down there. So now I go to quadrant mode. And I'm going to rotate this tip so that I can get the biggest purchase of the quadrant, okay? And you always want to go across the anterior chamber to grab the piece. You don't want to be grabbing a piece like this. That's awkward and you can tear the capsule. So I'm going to go here. And now I get to the point where I burrow the tip in a little bit. Now I'm just keeping constant vacuum and I'm extracting that into the iris plane. And now I'm putting the pedal down to phacoemulsify it. So now we're going to eat this piece. It's on a mode that's like an off-on burst type mode that allows, less heat to the tip of the phaco, so we don't get a phaco burn. And you always want to make sure you're tracking with your eyes, all those little pieces running around the anterior chamber. Okay, so I don't see any pieces around. We've got one quadrant already removed. So now I'm going to put my second instrument down here. I'm going to rotate a little bit, see if there's anything still stuck together. Those 2 pieces are stuck, so I'm going to kind of spread them apart a little bit. Okay, now this one looks like the most free one over here. So I'm going to rotate this one around. I always go across the chamber to get the piece. I don't want to grab it over there. So now I'm going to use my second instrument, keep this piece back, and I'm going to go and grab it, and I'm going to burrow my tip into it, and then I'm going to lift it up into the iris plane, and then you can go to town on it. You can still see it's maybe attached in the back plate because it's bringing the other piece up with it. That's okay. Okay. Now a little piece has floated over here to my wound. You always want to keep track of that. So I'm going to push that back in, bring my tip over here and grab that. Grab this piece. And now we're going to phacoemulsify this piece. Gonna finish there. Always want to use that second instrument to kind of keep things moving, keep things dancing on the tip of the phaco. You don't want to just be burrowing in, not getting anywhere. You want to see things moving around. You want to see fluid flowing through the anterior chamber. Okay, so last quadrant, we're going to spin it around. We're going to go grab across from it, burrow the tip in, lift up. Okay, so we're going here. Everything's fine. Now I can remove my second instrument. Modern phaco machines, they don't get a trampoline effect when you remove that last piece. I'm about 50% energy here. You can see how stable the chamber is. Nothing trampolined up. In modern phaco machines, it's almost more stable to take out that second instrument for the last piece than to leave it in, where you get egress of fluid from the eye. That's the last piece floating around. So you can kind of jiggle the eye sometimes a little to see if any pieces float around. Everything looks fine. So I'm going to turn off the continuous infusion. And I'm going to remove the phaco tip. And then the technician is preparing the irrigation aspiration tip for me. But so far, everything's going smoothly. And then we're going to move to IA. You can see the collar on the INA handpiece about the same length. Continuous irrigation on. And now I enter the eye. Now go for that subincisional cortex first. It's the easiest time to get it because the whole bag is being supported by the rest of the cortex. And that makes your life easy, especially in a floppy capsule. When you're trying to get those last pieces, it can be difficult. This is a pretty nice firm capsule, so it's all good. But you can see you just go around, remove the cortex very, very smoothly. Okay, almost done. Going across. This is the easiest part to get here. So we did the hard part first. That's another tip. Now I'm going to change to what's called vacuum or polish, and I'm gonna go get that little fragment on the posterior capsule. So now all the little remnants are gone. You can see the nice round capsulotomy, all the cortex and the cataracts removed. I'm grabbing the collar here, like I talked about. I'll show you guys again here. This viscoelastic doesn't have the guard, so I screw it in. I always make sure I just do this subconsciously, and then I always hold just like that right there. So when you inject, it doesn't go anywhere. So now this is a cohesive viscoelastic. We're going to inject, and our goal is to expand the capsule and the bag as big as we can get it. This is very easily removed from the eye, so you can put a lot of it in there and not be scared. Now this is the lens. It's a Johnson & Johnson one-piece acrylic lens. The technician's already loaded it for me, and it looks like it's in good position. So all I have to do is crank that little knob, and we'll get that into the eye. The way I enter the incision as I go right there, kind of, and then I rotate maybe 30 degrees. And then I use two hands. Inject that booger into the capsule right there, remove. And then I like to use what's called a push-pull or a Kugelin. I enter the eye, push the lens down posteriorly, and then free it up if it's stuck to the center of the optic like that. So I know that haptic's free, and now I look over here, that optic's free, so we know we're good there. So now I can use the irrigation aspiration on viscoelastic, which has more vacuum and more flow. And then you can just kind of keep it in the middle of the eye and put the pedal down, and all that cohesive viscoelastic comes from behind the optic. You saw it all come right there. You can, some of the dispersive is still stuck near the cornea, so you can go up a little anteriorly, and you guys can't see because it's very subtle, but you see little change in like reflection and patterns on the posterior aspect of the cornea when you're removing that. So we've removed all the viscoelastic. The lens is centered nicely. Remove this from the eye. And now the last part comes with the hydration of the wounds. So this is intracameral moxifloxacin and dexamethasone that I just injected right there, about 0.3 cc's. And now this is basic salt solution. I go into my main wound and I do stromal hydration on the lateral aspects of the wound. And then you can even put some into the roof of the incision like that. And now I'm gonna come over and check through my paracentesis, what the pressure is in the eye. Okay, I need to firm it up a little, but you notice that it firms up nicely. There's no egress of fluid from here. And can I see a little Wexel just to check the incision and show you guys, so you can kind of touch gently here. It's staying dry, so we're good. So the case is over. So I'm going to take off my gown and we'll undrape the patient, and then we'll talk to you a little bit more about cataract surgery. Okay, thank you.
Yeah, thank you, James. And I really like the techniques he demonstrated. No matter what kind of cataract you're facing, a dense cataract, a soft cataract, you can always use a divide and conquer technique. And I think what was really important was the patience he showed. We're going to start trenching or grooving the cataract, get down to the right depth, put the phaco tip and the second instrument at the very base and get a crack. And if you notice, his first crack didn't go all the way across. James was very patient and went back and made sure that the leathery plate or that adhesion was broken. You always want to make sure the segments or the different quadrants are completely mobile before you start disassembling the pizza. James, I think you're now ready to answer questions or continue your lecture. I think there are no questions that I saw in the chat, but obviously we encourage people to put them in. If you want to go back to your lecture and kind of go through some of the pearls for this surgery and the next surgery, that'd be great.
Okay, thanks, Hunter. All right, everybody. So I'll continue with the lecture a little bit. These are some common intraoperative issues that we deal with. What do we do if the chamber deepens suddenly like that? This is an old video, but it shows it nicely, especially in a myopic eye. When you insert any instrument in the eye that has fluid, it can cause the chamber, kind of a reverse capsular block syndrome. What you need to do if it's an INA handpiece is put the tip of the INA handpiece under the iris and lift up, and you free it up and the chamber will get a good depth. Patients will often complain of pain when this happens. Now, if it happens with a phaco tip, you can't stick the phaco tip under the iris, but you get your second instrument and you lift up the iris. So again, that's what you do when the chamber deepens suddenly. You have to, if it's an INA handpiece, you go in and lift the edge of the iris with the INA handpiece. If it's a phaco tip, use your second instrument. How deep do I groove? This was the question that I was talking about while I was doing the case. This is not a femtophaco. This is just a normal cataract. You can see me doing a central groove here. The trick is you have to go 80% before you can crack. And the way you know is you see these little stria, these horizontal stria in the groove there that tell you that you're at the right depth. So let's do that again here. Once you get the right depth, you'll start to see the protein fibers in the lens change, and you see them like this instead of like in random fashion. So that's how you know you're at 80% depth. When I was learning phaco, nobody ever taught me that. And I kind of figured out over time that once you started to see the grooves look like this, you're at the right depth. Okay, this happens often. In this case was the same. What if I don't see a wave when I'm doing hydrodissection? So a very common error when you're learning phaco is to be too aggressive with hydrodissection, and then you get iris prolapse, and then you get viscoelastic coming out of the eye. So you got to be gentle. And if you don't see a wave, you just have to keep going to different spots in the anterior capsule area and injecting gently, and then always ballotting, always pushing posteriorly on the lens to get any kind of pressure released. Here's a mature cataract. Again, this is that same thing. So if you don't see a wave, just do little gentle amounts all the way around, pushing posteriorly after each injection, and then eventually trying to spin the nucleus. If you can spin it a little bit, you're golden, okay? Okay, what if I can't rotate the nucleus? So you can see I'm at the right depth here. I have the little stria going there, and then I'm able to crack it. But if you can't rotate the nucleus, this is a very common problem, and especially if you have a really dense type nucleus. So here I did that first crack, and now I'm going to try to rotate it. But look, nothing wants to rotate. The lens just kind of shifts over. Now, what you can do is try to remove a small piece of it and just try to debulk the nucleus in situ. So you can see I made another groove, but not a whole quadrant, just kind of like an eighth of it. And then I broke that. And now here I'm trying to remove that section. And that allows you to free up the nucleus a little easier. So I removed that section, and now I have more room. Sometimes then it's easier to rotate it at that point because you can fracture it in pieces. So I'll show you that's still shown in the back. So if you're doing divide and conquer and you cannot rotate the nucleus, you can always repeat hydrodissection. That's the first thing that you can do. Even if you already started phacoing, you can always go back and do hydrodissection. If that doesn't work, go back, and instead of removing a whole quadrant, just remove an eighth. Remove that, and then crack subincisionally, and you're able to free up a quadrant. And then once you've removed a part of the, like over a quarter of the nucleus, it's going to spin a lot easier. Okay. So this is tricky. I wish I had a case where I was doing this and I wasn't able to rotate it to show you that. Maybe on my next webinar, I'll purposely try to not rotate it so you can see how to do this, because this is a nice little maneuver that you can learn. So again, if you can't rotate it, repeat the hydrodissection. If that doesn't work, remove an eighth of it and then back crack, and then try to spin out that last half nucleus. And once you've got that removed, you're good. Okay, the last thing I'll show you is managing a leaky wound. So there I here I'm doing stromal hydration of my main incision. And then this is what we do at the end of every case. Maybe I made this tunnel too short. And then now I'm injecting the paracentesis again. And you'll notice fluid egresses from the eye. And then I keep doing it and keep doing it. If this happens, you don't want to leave an eye soft, because when you see them the next morning, they're going to have iris coming out of the wound. So what you have to do is repeat the stromal hydration several times. If that still doesn't work, then you just need to put a suture in. When you do the stromal hydration, you can hydrate the lateral aspects of the wound, or you can do it into the roof, inject into the roof of the wound. But here, the better part of valor is just accepting that you didn't make a great incision and suturing it, and then remove that suture at 1 month, 1 week rather. Okay, any questions, Hunter, about phaco?
Yeah, just a few things. One was the incision size. I think you used a 2.6. Is that correct, sir?
That's correct.
And it's a triplanar wound. The other question was, if you have an intumescent lens or a white bulky lens that's under a lot of internal pressure, are you able to use femtosecond laser to make your CCC if you can't see through the lens, or if it's intumescent?
You can. From my experience, it's pretty good in those mature cataracts. It makes a nice capsule. It does it fast enough where the fluid doesn't come up. Now, if you suspect that you didn't get a capsulotomy with the femto, I would put trypan in and kind of observe to see what's going on. I wouldn't just trust that it was that it did it 100%.
And another question was, at the end of the case, you had your lens where both haptics were in the bag. The optic was covered by the CCC, but maybe it wasn't perfectly centered. Is that something you worry about, or do you find that the centration occurs over time, and as long as the lens is in the bag and the entire optic is covered, you feel like you're safe and not to fiddle around, because obviously the lens can shift a bit until it saran wraps in?
I programmed the femto to do a 5 millimeter rexus. So normally it will cover the optic, because the most optics are 6 millimeters. So you have a good margin of error on each side. So it doesn't have to be perfectly centered on the rexus. Sometimes it doesn't want to, especially if the bag's a little floppy, but as long as it's covering the optic, we're good.
And do you ever use the soft shell technique? I know that that's something that the first person wanted us to ask. Do you ever use a soft shell technique for removing the lens?
I don't really find that it's totally necessary, especially if you've done the femto first. The soft shell is helpful if you're maybe having a hard time keeping keeping the pressure flat to do a nice capsulotomy. But I think if it's a really dense lens, you can always inject more dispersive if you feel like that's needed. But most of the time, these corneas respond fine.
And then, James, the last question, and this is from Dr. Ahmed that just came in, is do you use the temporal side for the paracentesis in all your cases, or just in cases where you don't have good exposure? What is your preferred? Yeah, what is your preferred location?
I always operate temporally, and then I'm right-handed, so I'll make my main incision somewhere around the most temporal aspect, and then the paracentesis would be kind of 40 degrees to the left of my main wound.
And I like that, because obviously we know where natural astigmatism occurs in most patients. By having the wound temporal, you also relax some of that astigmatism, but you're not changing your technique based on the patient's brow. I know some doctors get really nervous if they always operate superiorly or superior temporally, and then they have a patient with a sunken eye or a high brow. I like your technique that you're doing that for every case, no matter what. That allows you to have a lot more standardization and comfort.
Yeah, I think in most countries that I visited, surgeons still operate superiorly, but I think it has to do more with the availability of beds that are comfortable to get your legs under to operate temporally, because temporal surgery for cataracts is much easier. You got more space. I'm a big fan of it.
And then the last thing which I loved was obviously you were trying to create a safe working space by debulking the lens by the divide and conquer space of the center of that plus sign, but also you were able to get that first quadrant and bring it to a safe space at the iris plane. Do you always like to keep the phaco tip in the iris plane during quadrant mode? That's the question.
Yeah, that's the best place to do it. It's the safest, less trauma to the cornea, less risk of damaging the capsule.
Yeah, I agree. And I think the thing that I really appreciated about that case was you always had control. You're not going to get into complications if you maintain control and don't push a bad situation. And I think by maintaining that center space where you're, as you said, farthest from the endothelium, farthest from the posterior capsule, you're in a good space. Now, James, I certainly can answer questions if you need to go attend to the next patient or get ready, but there are questions still coming through. How are you for the next patient, or are you ready for more questions?
We are they're getting the patient ready, so I still have probably about 10 minutes, I think. I can go
Okay.
ahead and I'll go ahead and talk a
Yeah.
little
So
bit about DMACC,
yeah,
yeah?
exactly. And I'll make sure we answer the rest of these cataract questions offline. So please start with the DMEK.
Okay, so why switch from cataract to DMACC? Well, in my surgery day, most of the time I'll do, X number of cataracts, but we will have some cornea cases thrown in. And so this is a kind of a representation of what my normal surgery day would be. So just to give a background to those that don't know, endothelial keratoplasty started in the 00s, and first it was very technically difficult, the DLEC, which was popularized by Dr. Terry, and then DSEC was invented around 2004, 2005. That's B here on the slide, where it's the endothelium decimase and a little bit of posterior stroma that have been cut on a microkeratome. But now what we do in most uncomplicated eyes is DMEK, which is just exact anatomic replacement of decimase membrane and the endothelial cells. So that's the bottom one, as popularized by Dr. Millis around 2007. So this is the kind of the evolution of endothelial keratoplasty. Why do we do DMACC? Because you get better vision and there's less refractive shift. I mean, it's an exact fix for the problem. You can see this picture here. That's a post-op day 1 from 5 years ago. Like, they can look that good. No DSEC ever looks that good that soon. Now, DSEC is good surgery, and it still has a place, but in an eye that's complicated, DMECC is the first choice. So donor's cornea selection in DMECC is different than PK. When you're doing a PK, you want this cornea with all the other good qualities, right? But age, you want it young. In DMEC, I don't go much lower than 45. And the main reason is that the DMEC scrolls too tightly the younger you get, and it makes the surgery more difficult. So 45 is kind of low range for donors, 65 the top range. Also, they tend to exclude diabetics because there's some evidence that it's more difficult to peel decimase off of a diabetic. So additionally, pseudofakes we don't use because they may have some incisions that protrude into that central 8 millimeters that we need for the DMEC. So what I'm going to talk about before the surgery is DMEC or DSEC. Like, so when I see a patient, how do I decide? This picture that you see there is a DSEC surgery. You can see the little wedge of posterior stroma on an anterior chamber OCT. So they're both good. The main thing would be DSEC is used in more complicated eyes, and DMEC is used in more, uncomplicated or virgin eyes. Now, if there's an ACIOL and you're not going to take it out, you pretty much have to do DSEC because you can't do a DMEC with an ACIOL. Also, DMEC has the risk of more return visits for bubbles. Sometimes you have to rebubble more in DMEC than DSEC. So if the patient lives really far away or has a hard time getting to the clinic, then you would maybe shift towards DSEC. The other thing is, in the US, the eye banks prepare the DMECs for us, but you're going to have to do that most likely in your home country. So you have to get a comfort level preparing the DMEC tissue, which oftentimes is as steep as the learning curve for the surgery. So this is kind of the things I think about when I'm deciding between DMEC and DSEC. The main thing is the complexity of the anterior chamber. If it's shallow, if there's any angle closure, if there's a valve, most of the time I'll tend to do DSEC in those cases. If the cornea is really cloudy and I don't think I have a good enough view for DMEC, you don't need a good view for DSEC. So you could do DSEC in those. If there's iris defect, the iridotonis, those I would tend to do DSEC as well. And then the lens status has to be addressed as well. I don't do combined like DSEC surgery. If it's complicated, I would do the IOL exchange first and then come back and then do DSEC. If it's straightforward and it's Fuchs with a cataract, then I would do DMEC phaco. So here's some photos from my colleague, Dr. Aldave. These would be cases in which we would not want to do a DMEC surgery. So like on the top left, you see a old school style ACIOL and a edematous cornea with multiple PIs. The eye looks angry. That one needs to have an IOL exchange first and then go and do a DSEC. The same in the upper right. And then the lower left, all that fibrosis, that patients had long-standing corneal edema leading to fibrosis. Now those, most likely that's view is going to get a lot better and you could consider DMEC, but you're going to be safe bet to do DSEC in that surgery. And then lastly, that's an aphakic with really no iris tissue. That's going to be a DSEC for sure with like a little safety suture so you don't have to worry about the disc falling to the posterior chamber of the eye. Sometimes if you can't get a good view of what's happening, you can do an anterior chamber OCT prior to surgery, and it can help show if there's some distorted anatomy, make you more comfortable with your decision about doing DSEK. Basically, if you don't have a good enough view and you got to do a pre-op OCT, you should be doing DSEK in that patient. So again, summary of like preoperative planning for DMACC. I generally do peribulbar anesthesia. That's what I'm going to show you here. Patient needs to be able to lay flat for the first night of the surgery. Generally, it's in uncomplicated eyes. That would be in the US, mostly Fuchs dystrophy patients. And especially when you're learning it first, you don't want to do eyes with complex pathology. And then I do the inferior iridotomy with a YAG a week before surgery. So that's where we'll stop with the, I'll talk about the instruments, and then I'll show you the surgery. So the good thing about DMEK surgery is you don't need a lot of fancy instruments. You have a cataract set, and then you basically need a reverse Sinskey to score the endothelium. You need a trephine or some sort of optical zone marker to mark the 8mm center of the cornea. And that's about it. I use this as a handheld slit lamp to help determine orientation. But nowadays, people just get the little stamp on the tissue, and that's an easier way of doing it. I just kind of learned this way, and I still do it with the slit lamp. All right, so I'm going to stop there, and then I'll go ahead and do the surgery, and we'll finish talking a little more about DMEK, okay?
Yeah, that's perfect, Dr. Lehmann. So as you get ready, we're just going to talk again. All of these techniques and all of these materials are available on CyberSite. So if you look in the chat, please visit the CyberSite e-library. Certainly our team is always welcome to feedback. If there's videos or lectures or materials you want, please let us know. Certainly cornea is a growing area for us. This is the first time we've done a DMEK surgery live on CyberSite, so certainly appreciative and excited for James to demonstrate. I think as you have questions, please let us know, whether it's about the bubbling technique, whether or not you need to do an iridotomy, or what you look for the next day and how you treat that patient is very important. I see that James is still prepping the patient and on mute, so we're going to talk a little bit about the lamellar procedures. I think what's really important, like every case and every procedure, is patient selection and patient education. Patients have to understand their role in the successful bubble and positioning. If the patient is not able to do that for a multitude of reasons, then certainly that's something to discuss. So not one size fits all is appropriate when looking at a corneal technique. And certainly, as Dr. Lehmann said, we want to look at the other components of the eye. For example, this patient has already had a successful DMEK in their right eye. Today we're doing the left eye. But during the exam, Dr. Lehmann noticed that the patient had a chorioretinal scar. It's really, really important to do a complete eye exam, especially of the retina and macula, even for patients where you're not going, only working on the cornea, so that you know if they're visually limiting findings or pathology in the retina. Dr. Lehmann, I see you're at the slit lamp. We're in perfect focus. Are you able to
Okay.
take over and tell us about this
Yeah.
patient?
Yeah, I will. So, okay. So, okay, ma'am, we're going to get started. So here we are. We have the patient. As Hunter said, she still has pretty decent vision around 20/50. She has some gutata and a history of cataract surgery. And that's the iridotomy I did last 2 weeks ago in Fairleigh. So how I start DMEK surgery is I use some traction sutures through the episclera. And the reason I do this is because sometimes, especially in an eye where you can't deepen the chamber, you can't flatten the chamber to get the graft unfolded. Sometimes you have to rotate the eye into different positions, and that's where these traction sutures come in handy. So I know a lot of surgeons don't do these, but when I learned it, this is how we did it, and it definitely comes in handy. So especially like if we start doing this case, reload that for me. If we can't do this, like if we can't shallow the chamber easily, it's very helpful to be able to rotate the eye and be in control of it. So I'm going to place 2 traction sutures right now. I'm just tying it. And this is just a silk 4/0 suture on a tapered needle. And what you do is you just, the way I like to hold these is about 3/4 up the way here. And then you go about 2 millimeters posterior to the limbus. You grab a little bit of conj and you push the needle into the episclera. You feel it kind of grab. And then you just want a nice episcleral bite. You don't want to use you can use a spatula needle or you can use a taper needle. You don't want to use a cutting needle because you'll go too deep into the sclera. So now I'm just tying this silk suture. Again, this is kind of old school. A lot of docs don't do this anymore, but I'd rather do it now. And then if you can't shallow the chamber or you can't get that graft centered, it's very helpful. So the next step is to mark the central 8 millimeters. So this is an optical zone marker. And you just want to do this over like the geometric center of the cornea. You don't have to mark it right on the pupil. So that's the geometric center. And then now I use a fine marking pen and I put dots where I made my ring. All right, so we got the cornea marked. Okay, now we're good to go. Now we know we're going to need to strip. Now I use a super sharp blade, 15-degree blade, and I need to make 2 pairs in TCs. So I'm sitting temporal. This is where I'm going to make my main wound. So I want to make one here and here. Again, nick a limbal vessel slightly so that you know where it is. And you want it about 1.5 millimeters in width. Changing hands now. I'm going to fixate the globe. And then I'm going to come in the iris plane. And I'm going to make a 1.5 width incision. Now I'm going to inject some cohesive viscoelastic. Again, I'm holding the little cannula area there. Now, cohesive is very important because when you do score endothelium and stuff, you need to then remove what the viscoelastic. And if it's dispersive, you got problems and it's going to make the rest of the case a lot harder. I can see the patient's previous phaco wound here, so I'm going to kind of stay clear of that. These wounds can be pretty short. It doesn't have, you don't want it to go into that area where the graft is going to be, and you're going to suture it anyway, so it doesn't have to be such a long tunnel. So I'm just going like that. All right. And now, if you put BSS on the cornea for me, now I'm going to focus right on the cornea. And this is that reverse Sinskey hook. And what I want to do is I'm going to enter the eye and I want to score it in that central 8 millimeters. Now, when I'm doing this, you're going to want to see that I can move pretty gently, pretty freely, fast like this. If you see me and I'm like, then I'm too deep, too into the stroma, and you're causing tags and tears. That's going to make it harder for the DMEK to adhere later. So I rotate it 90 degrees into the anterior chamber, start right here, and you see a little bit of whitening. That's all. You can see I'm moving pretty fast around this circle. And I'm scoring decimes right here. That's all. So you want to be able to flow gently. Now I go around twice in that same line that I was in, because I want to make sure that thing's completely torn. With DSEK, you can have some tags and stuff left behind, but with DMEK, you don't want that. So I've already gone around twice. Now I'm going lateral to where I started, and now I'm putting a little pressure, and you can see it starts to come now, and it's coming in a nice, you just pull in on the center here gently. It's coming as one big uniform piece of endothelium and decimes. So I'll get some straight tires here in a second. So I'm pulling out of the wound. Now here it's on the cornea. See the straight tire? And then this is the kind of the intact decimes membrane. Came out nicely all in one piece. Kind of unfolded for you guys if I can. You kind of get the idea here that it came out all intact and nicely. There we go. That's what we removed. Right there. Okay, so now we send this to pathology to confirm the diagnosis. Now I'm going to put a little BSS on the cornea to get you a good view here again, center the camera. Okay. All right, so now we have to we're going to pre-place a suture. So I'll take my 10-0 nylon suture. After we inject the DMEK graft, it's the less manipulation of the main wound you do, the better, because sometimes it can be, it can kind of expel itself. Reload that for me. Okay. So we're going to put this 0.12 right here. That's my paracentesis. That's my main wound. They're going to have to go get me another suture. Is that? No. Sorry about that. The suture fell. So we're just getting another one here. You can turn the room lights on, guys. All right, I'll do INA here. So we got to remove the viscoelastic. So I'm using the INA handpiece. And this is pretty easy. Just going to be real thorough. Make sure you remove all the viscoelastic. All right. I don't see anything fluttering. Sometimes you can see tags fluttering. That tells you there are little parts still there. I don't see that. So, okay. So now no more viscoelastic in the AC. My tech is handing me the suture. I like to hold the suture 3/4 the way up, just like that. Now I'm going to use my 0.12 and I'm going to insert the tip into the wound, get an idea of where the lip is. There we go. So now I'm going to pre-place this suture. Okay, now I'm going to hold the scleral end. And then, so that suture is pre-placed. I'm going to pull it through halfway. Can I see the Utradas real quick? When I'm here, I see a little bit of Descemet's membrane still present right here. And I'm just going to remove that little tag right there that I saw. Okay, so now we're good. Now we're going to prepare the tissue. So I'll take the cornea tissue. Okay, so here you see it floating in the tube. This is a glass cannula, the goiter glass cannula. This area right here, that's the graft. It's already been stained and peeled, and it's free floating in solution. And so what I need to do is I need to connect it to this thing, which is a 3 millimeter syringe. So what I do, I'm doing this all over a petri dish in case I drop the cannula or the glass cannula. I uncork it on one side, and I'm coming and I'm putting a little bit of fluid, just a little bit. Okay, now I'm going to remove this side. So that's gone. And now this is going to drain out that preservative, the medium solution. You can see it starts to fall down now, and you can see the difference in the viscosity of the two materials. As I lock this cannula on, I'm going to inject and keep it in a kind of an elevated plane, and the graft will stay in the same place, but the medium will come out. You can see that viscosity change. So now we're kind of flushing out the medium. So now we're just full of BSS. And now I'm going to put it horizontal, and I'm going to advance it a little bit. Now I'm trying to advance that tissue a little bit to that real narrow neck. I want to get it to like right there. And then I'm going to transfer it to the Mayo stand. You can't see me do that, but I'm transferring it to the Mayo stand. Now I'm done prepping it, and I'm going to go back to the eye. And now we're going to inject it. And then my technician is going to hand me, after the injection, you're going to hand me tying forceps. So y'all can see that again. Okay. Now I'm getting the tissue again. Give me another 3cc syringe. So that 3cc syringe came off the back. So that was unplanned, but we get good to see what happens when that happens. So I'm going to reattach one. You don't want that to advance out the end of the tube. So I'm going to firmly kind of tighten that nice and firm. Look pretty good there. And then I may need 0.12s. We're going to advance it into the neck of the injector just a little bit more. That's good. Now I'm going into my wound, and I'm going to inject it. Now watch, I'm going to use this. I'm going to rotate it so that it won't come out of the wound. So it's perpendicular to the wound. So now it's like that. Now I need little tires. I'm going to zoom out so you can see the tires. The eye's pretty flat right now, but the chamber's staying deep. Things going good. Suture stuck on something over there. There we go. Little BSS on the cornea. And now I'm going to tie my incision. This is just a 3-1-1. There's 3. Lock my knot. 1. 1 the other way. Scissors. I'm going to cut my suture and rotate the knot and bury it. And then this suture comes out about 2 or 3 weeks after surgery. Here's the suture back. Okay. And I'll take the big BSS on a 10cc syringe. So now we're going to inject BSS through the paracenteses and get this in the right orientation. So this is where DMEK's kind of fun. If we tap on it, what's happening right now? We're getting it to unfold, okay? But right now, if you look at it, it's pretty much folded in half like a clam. So it's in the correct orientation. I can see it's curved to the right orientation. But if you give me another cannula, or just another like that one right there. Sometimes you can get lucky and you can hold on one side and you can like open here like that, and you get it to unfold like a bouquet. So you see now we're getting it to open a little bit. So now it's in the right orientation, you see. Now I need to verify that. So I'm going to deepen the chamber a little bit by injecting some fluid, and then you're going to give me the flashlight. And I'm going to use that little flashlight, and we're going to see that it's in the correct. Now we're going to confirm the correct orientation, okay? So I'm using that beam, and I'm looking on the cornea, and we're seeing two edges of the graft. So I'll illustrate that. It's in the correct orientation. Turn the room lights on again. And then give me a little piece of, give me one of those piece of paper over there or something. Yeah. All right, guys. So I'm going to move away from here. I'm going to show you what I just saw. So here's a piece of paper. Zoom out.
Yeah, zoom out a bit, James. Some of us are
Okay.
still presbyopic. Okay.
Can you all see that piece of paper, right?
We can, yes, sir.
All right. So it's either like this or it's like this. This is bad. You want it like this. You want to see
Correct.
two sides of it, like two rolls. If I shine the light on it and I just see one roll like this, it's not right. You want to see two humps like this, okay? And that's what I
Correct.
saw, okay? So I know it's in the correct orientation. So move back. That's sitting in a perfect orientation in the eye, like a tricorn hat. And now what I have to do is I have to get it in the right spot. So I'm going to use little air, which is this is a 30 gauge needle on a 1 cc syringe. And I'm going to pull up this much air, just like that. Okay. And then I'm going to look bevel up. I'm going to rotate. I'm going to bend the needle a little bit like that. I'll come back. I'm going to go through my paracentesis. And then I want to gently put this under the graft and put an air bubble, and it's going to pin it to the posterior stroma. On my, oh, can't find my paracentesis. Oh, it's got to be right here where I nicked it. There we go. And now I'm getting under the graft. Now I'm going to put an air bubble. I want one air bubble, not 3, but we got that there. Now I need to be assessed. Now I'm going to fill the AC a little bit. The graft is pinned and it's unfolding already. We're good. Now I just need to get this last fold here out. So I'm going to rotate. This is where I'm talking about rotating the eye. So I rotate it so the bubble is centered on the graft. And then I'm going to push on that fold right there and look at it just unfold. And then here, just going to push there. So now it's totally unfolded. It just is not centered. So I'm going to rotate the eye a little bit superiorly so the bubble is correct underneath the graft. And then I'm going to put these little gentle strokes like this, little golf strokes, and I'm going to use that to center the graft. So it's almost centered.
Your surgical game is much better than your golf game, Dr.
I
Lehmann.
know. I wish they were both good. I don't know what that noise is. Okay, it's oxygen shipping. So now we're centered. You can see that. Maybe it could be a smidge superior, but anyway, we're good. So now what we need to do is we want to get that graft to stick nicely. So now I'm going to do it. This is more air. I'm going to go underneath, making sure I'm under the graft. I'm going to augment that air bubble by putting more. You can still see everything's good. You see the outline of the graft here. We know we're good. Okay. This air bubble is not enough. That eye's soft. You want it firm. I leave it firm for 45 minutes. So after I make it firm here, the patient's going to go out to holding, and then they're going to hang out for a little bit and come back. And then I'm going to remove enough air to clear the inferior para. But for now, I need to put more air in. So I'm going back. Now, this is the real tricky part. And this is what you learn when you do DSEK. I'm not going to put this cannula back in the eye and inject air, because any air I inject will come out as I'm pushing down on the wound. So I have it prepped. I have the cannula prepped already. I'm putting it like halfway into the paracentesis, and I'm injecting air. And that's how I firm up the eye. Even though there are a bunch of little bubbles, it's all fine. I still see the edge of the graft there. So now that's a firm-ish eye, and that's what we want. So all those bubbles will coalesce in the next few minutes while the patient's in holding. But anyway, that's DMEK surgery. That graft is stuck, it's centered. And then I'm going to remove these traction sutures, and the patient's going to go lay flat for 45 minutes, and I'm going to come back and I'm going to remove the air bubbles. So.
Okay, perfect. So we have about 5 questions at the moment for you.
Okay, go ahead.
So the first one is, obviously back when you were doing your fellowship, they talked about the triple procedure where you did a full thickness PK, the cataract extraction, and an IOL. Are they doing combined DMEK surgery where they're doing phaco or cataract removal at the time of the DMEK lamellar keratoplasty?
Yes, I do DMACC and phaco at the same time, just to save the patient a surgery. But if the eye is complex, like I'm doing DSEK and I'm doing IOL exchange, then I would do them separately. But if it's uncomplicated phaco, uncomplicated DMACC, do them together.
Great. And then the next question is, I think you mentioned that DMEK sometimes requires more rebubbling than DSEK. Is that because it's thinner and flimsier tissue? What is the reason in your experience or in your mind of why DMEK may require more rebubbling?
The tissue, you stick it, but it wants to curl away. It always wants to push itself away from the posterior stroma. So you're using an air bubble to stick it until the cells wake up and start their sodium potassium pumps and stick. Preparing DMEK is more difficult, and the cells can be damaged. So cells on it, and it just won't stick. So just DMEK's just riskier. It's less certain of the outcome as DSEK. Even in the best hands, like that surgery, I didn't even have to rotate that graft, but one time maybe that still could not stick. Like it's a little bit of out of your hands as a surgeon. Like you do the surgery well, you ensure it was prepped well, but sometimes the graft is just, they just don't want to stick. So that's the difference between kind of DMEK and DSEK.
And so the answer is maybe there's more concussed endothelial cells due to the DMEK preparation. And then mechanically how they scroll, that there might be more of a challenge because as you said, they're trying to push away from the stroma that they're trying to readhere to. The last question, a couple quick questions. How long do you have the patient? I think you said 45 minutes. How long do you have them keep supine both in your ASC, your ambulatory surgery center, and how long do you tell them to stay supine when they get home or in the car ride home?
We have them lay flat 80% of the time, just the first night, and then we check them and see how they're doing the next day. Most of the time, DMEKs are stuck on day one, and then we don't make them position anymore. But probably 10% have to be rebubbled. Even in great hands, 10% have to be rebubbled.
Yeah. So which gas did you use for that bubbling? Was it just room air?
I just use air. I just use air.
And if you were to estimate, how much volume do you inject on the primary bubble, the second bubble, and the third bubble? Like as you do these, what is the volume you're doing? I know it's probably more visual and by feel, but what are you estimating?
You want the eye firm. That's the thing. You want to touch the eye and it feels like the pressure's, 40. You want it firm. If it's too soft, I don't think you have enough force sticking that DMACC to the posterior stroma. So I don't know the volume because you actually deepen the chamber with the air bubble, but it's enough to make the eye firm. And then they go hang out 45 minutes. You bring them back in, you reduce the air bubble to about the size of the graft when the patient's lying supine. So that translates to like a 3/4 full AC afterwards.
So to answer the question, it's not a set volume. It's more of how anatomically the bubble is functioning and sitting in the eye. Just so we heard you correctly, you're going to have this patient supine for 45 minutes, bring them back into the operating room and look at things and potentially lessen or shrink the bubble just a bit, just so it fills the circumference of the graft. Is that correct, Dr. Lehmann?
The diameter of the graft, yeah.
Yeah. And then two quick other questions. Is DMEK contraindicated for patients with chronic uveitis? So if a patient has chronic or active uveitis, either one, are you hot to trot with DMEK?
No, I have done this in patients, like young patients who get endothelial decompensation from HSV, or I've even had a patient who had CMV endotheliitis. I've done that, and it's okay. What's interesting though is that they don't last as long. Like it's not going to be 10 to 20 years on that graft. It's going to be like 5 fully. And you got to have them on you got to keep them on viral prophylaxis. So like valacyclovir, but if it's CMV, you could do ganciclovir or valganciclovir.
I love that. And then the last question for you, Dr. Lehmann, other than the compliments for a great webinar, that one of the questions that Dr. Paramita is asking, is there any indicator or things to look out for when the graft doesn't adhere or center properly? What are some watch outs, very subtle clinical things you're looking for that could suggest that there's not good adherence, not good contact, or not good centration?
You have to strip slightly bigger than the put in, okay? Because you want the DMACC stuck to posterior stroma, not to remnants of endothelium. So you want to make sure you strip a little bit bigger. You want to make sure there are no folds in it. That's easy to see. But centering it can be difficult. Like the way you're trying to throw it to the middle. Sometimes you can't center it, and you have to redo the whole thing, like re-inject it and get it to fold again. So sometimes that, like there's a strand of vitreous you can't see, or there's fibrin in the AC that can sometimes do it. But sometimes it gets stuck in the angle, and it's a pain in the butt to get it centered. And in that situation, you got to sometimes start back at the first step. So I can show that here in the.
Yeah. So why don't we get back to your lecture? There's one more question, but I think you're going to answer it during your talk. So let's get to your talk because I know we're at the end of the hour.
So this is the steps of DMACC. This is what I showed you in the surgery. You can see me stripping slightly outside where I made those dots, because you want to make it a little bit slightly bigger. You don't want it way oversized because you'll get this ring of edema around the DMACC, but you want to do it at least in a way where you're not going to have overlap of the posterior endothelium that still remain and the graft. This is a DMACC phaco. You can see that this patient's pseudophakic and the pupil didn't come down all the way, because sometimes even with Myocol, it doesn't come down all the way. So a lot of surgeons don't like doing combo DMACC phaco for this reason. But if you get enough confidence in your technique and stuff, you can do it. You can add Myocol. So this is that stripping of the decimase like we showed. And then these are the steps that I use to get it to stick. So first I unroll it and I confirm the orientation. Then I unfold it and I center it. So we'll go through these again here. So when it's been injected, if you need to flip it, this is how you do it. You inject fluid underneath it, and then you kind of get it to unroll. So I'm just going to show this on a loop. So when you have it in the eye and you know it's not in the right orientation, you got to make it flip. And the way you make it flip is you inject fluid underneath it. You create a fluid wave on the top surface of the iris, and it makes the graft flip just like that. Okay. So that's when you need to flip the orientation. That's how you do it. Now, you got to get it to unroll. So most surgeons nowadays, and what I just demonstrated is like a double tap. So if you need to get it to unfold, you either tap it or you release fluid away from where the graft is. You'll see here. So here I'm just tapping it. I'm trying to get it to unfold. There it's starting to. It's like 2 scrolls there. That's nice. It's pretty good there. That was pretty easy to unscroll there. That's the easy way to tap it. Okay, but sometimes that doesn't work. So sometimes you got to release fluid. That's what I'll show here. So now I touch on the incision. Look right there. You see how I touched on the incision, and it opened that bouquet up a little bit. So touching on the incision. So you can either tap or you can open an incision, and then you get in that orientation. That's the fluid coming out of the eye causes the graft to open in that direction. You can see me tapping, and then I'm going to go in the other paracentesis here. And then I'm just tapping that paracentesis and look at it open up nice. And then that's that tricorn hat. We had a lovely tricorn hat in the surgery. You could see it easy. So this is what we want. That's what we had in the surgery. Once you get in this orientation, you have to determine, is it upside down or is it in the correct orientation? And that's what we use the light for. So you see here on the side here, we want to see those 2 humps like this. You want to see it like this and not like that. So you can use a flashlight for that, or it can have the S stamp or the F stamp. I don't like the F stamp because it sells in the air and have a big F on the time. But anyway, you see the 2 humps here. That's what we like. And then I have it in the right orientation. Now we're going to put air underneath it to stick it to the posterior stroma. So small air bubble, boom. Now we want it to unfold. So you just touch on that point and get it to unfold. This is the fun part. Makes you feel like a hero. Sometimes if you can't get it to unfold, you push between the bubble. You can push between the bubble and there, and you got it to unfold just like that. So this is that same thing. You can sometimes rotate the eye if it's being stubborn. In this case, I have too many air bubbles in the eye. That's not very aesthetic. And then you push between the bubble and the fold, and sometimes the bubble will roll up and undo it. And then if it's locked like this, you can rotate it, get some pressure, and then you touch on the point of that fold there, and then it opens nicely. So once we have the graft centered, then you put a full air bubble. So you start by making sure you're under the graft, you augment the bubble that's under the graft, you fill the AC, but that's not firm yet. That's just filling it. And then you go in with a 3 cc syringe, and you fill the eye firm. Then the patient lays flat for 45 minutes. You bring him back and you remove some of the air. So in conclusion, the phaco tips and tricks. Remember, nick the vessels to mark your incision. Hold the cannula collar for OVD injection. Make a square main incision. You don't have to hydrodissect a mature cataract. Get the subincisional cortex first. And the way you know the groove is the right depth is until you go 80 perpendicular to the tunnel. DSEC decision tree. If it's hard, do a DSEC. If it's forward, that's what all that stuff is saying right there. So,
Dr. Lehmann,
yeah, go ahead.
Real quick. First of all, those were great summary points. I think you demonstrated beautifully femtosecond assisted cataract surgery, and then the DMEK procedure. A few more DMEK questions that we had. One is, and I wanted to save this for the summary, what is your preferred anesthesia for DMEK? Is it topical? Is it a block? What do you like to use
A
for
block, a
DMEK?
block, a
Okay,
block. I've tried to do it topically, and the patients just have too much discomfort. So
yeah.
I think a block's the way to go.
Yeah, and I wrote in the chat that really that's based on the patient selection and comfort as well as the surgeon's comfort. And obviously, when you're manipulating the eye, I love those stay sutures, how you could rotate and move the eye to your advantage. That's something you're going to have to do when the patient's blocked. Two quick questions. One is, what do we do if the graft is oriented in the wrong direction? So you did that flashlight check, you look to see, and instead of having the dome, you actually have those two curls. How do you flip or rotate that?
So that's the fun one. That's the flip
Yes,
right here. You shoot fluid underneath it like that, and it causes the graft to tumble over. So like
correct.
this.
So, right. So
Yeah.
maybe you could show that one more time so that we get that triangular, just in case not everyone knows that hat, that if you see that you're in the wrong orientation, you can just do a jet stream from the side port, right?
Yeah, you basically come if you are in the wrong orientation, you got to go back to step one, which is trying to get back to here. Okay, this is where you want to end up. If this is wrong, this is right in this video, but if it's wrong, then you got to go back and inject fluid underneath it and make it spin.
Okay, and then just two more quick questions, Dr. Lehmann. What if the air bubble or there's small bubbles between the flap and the stroma? How can you identify this, and then how do you correct it so that if there's something between the graft and the new stroma bed or the cornea, what do you do to remove those bubbles?
There won't be, just the nature of the tight fit, bubbles generally will not stay between an attached DMACC and posterior stroma. If they are, you can just massage on the top of the cornea and it will put them away. Now, sometimes when you're injecting subsequent air, it causes a fold to happen in the graft. If you see that, you have to extract air and then do some maneuvers to get it open again.
Okay, and then the last question, and then I realize you have other patients to get to, Dr. Lehmann, so thank you for beautiful demonstrations. What are the most common diseases you're using DMEK to treat? So Fuchs or, pseudophakic bullous keratopathy, what are some diseases that you're using DMEK to treat?
So I use DMACC. I probably do of all the transplants that I do that are endothelial, it's probably 80% DMEK, 20% DSEK. I'll do DMEK in PBK and Fuchs, and even in some glaucoma valves that if it's a pretty straightforward eye to, so pretty much it's my go-to. But if there's other things like an iris defect, if there's a angle closure, if there's mostly like an abnormal anterior segment, then I'll go to DSEK in those, but 80% of them get DMEK.
Okay. All right. Well, you get on with your day. Thank you for such beautiful demonstrations. All of these will be recorded and put in the CyberSight library. So if your colleagues were not able to attend live, they can review this. Dr. Lehmann, thank you as always for all you do. Do you have any parting comments? Is there anything else you'd like to say before you get on to your next patient?
No, I want to just thank you for being the MC, and I thank you to Orbis for giving me this opportunity. I appreciate it. Y'all have a good day, and until the next time.
All right. Take care, everyone.